So I have a short presentation on why the health system is in trouble. And I just sort of want to frame it for you. So first off, in case you didn't know, our costs in the United States are higher than anywhere else. This graph shows you the percentage of our gross domestic product that we spend on healthcare in comparison to the wealthiest other wealthy nations. Look, this one, the next one here is Sweden. And down here is the UK. We're double the UK. And you know, we're double Sweden and more than double the UK. Why is that? Can we afford it? Absolutely not. Now, what do we get for the extra money? Well, this is a survey that was done by the Commonwealth Fund that compared us to other wealthy developed nations. There are 11 of them. Our overall ranking is last. And some of the most important things to look at are access to care. That is, how easy is it to see a doctor? Who does that? We're 11th, we're the worst. Equity. Do people who are poorer come from underrepresented groups do as well as other people who aren't from underrepresented groups? No, we come in last again. And healthcare outcomes, that is, how well do we do? How is our health? When somebody is treated, is the outcome that you can expect maximized here? No, we're 11th again. And this year, you should know that our mortality rate has increased and our length of life has decreased by 1 year. Now, something good happened in 2010. The Affordable Care Act was passed and it was implemented pretty much in 2014. There were a few states that implemented it earlier. California was one of those. So when we started out, 42 million people in the country didn't have health insurance, and that was 17%. It rose at the time of that the ACA was enacted, or we sometimes call it Obamacare. It was almost 18%. After the ACA was passed and implemented in 2014, the uninsurance rate has fallen dramatically. So it's almost half of the numbers who were uninsured then are uninsured now. You can see it's been creeping up, and we don't have time to explain all the provisions of the ACA, but it's pretty much gone down to 10% from almost 18%. Now, the main reason that we've seen this is something called the Medicaid expansion. Medicaid is called Medi-Cal in California. It's the health insurance program that started out for people whose income was 100% of the poverty line or less. Now, what happened was that states were given the opportunity to expand, and in the first several years, the government footed the whole bill. That's important because in a state like California, we pay 50% of Medi-Cal bills and the federal government pays 50%. But when we expanded, and what the expansion did was it included people up to 138% of the poverty line, the government paid the whole difference. Now, in southern states like Mississippi, and the yellow are the states that didn't expand, they are much poorer than we are. So the formula is that wealthier states pay a bigger fraction of the Medi-Cal or Medicaid bill. So in Alabama and Mississippi, they only pay, the government pays 77% and they pay 23%. So several states are considering expanding now because the new relief bill is going to help them pay more. The states that are likely to expand are Wyoming and Alabama. Utah has already passed an expansion but hasn't implemented it. So that's going to mean that fewer people are uninsured in the future. Now, what has the ACA impact really been, and what did it do? What are some of the most important things? Well, it used to be that to be insured, you wouldn't be insured for pre-existing conditions if you changed your insurer. So that means I have a mild case of asthma. So if I switch insurers and the insurers are paying for my visits to asthma now, it would mean that I would switch to an insurer who wouldn't pay for it, and I would have to pay more out of pocket. Well, you know what? I'm lucky. I probably could afford that, but most people can't. So the ACA took it away, and everybody is covered for their pre-existing conditions, and that's one of the most popular provisions. Two of the other popular ones are the Medicaid expansion and the fact that if you're insured, your kids up to 26 can stay on your health insurance. And the ACA mandates that everybody has the same benefits, and they're very comprehensive. That means everything is covered. Now, what happened, there were some great things that happened due to the Medicaid expansion and the ACA. And that was fewer people are foregoing care due to cost. That is, a lot of people who would get from their doctor a prescription for some medicines and couldn't afford it then, can afford it now because there's greater coverage and less out-of-pocket costs. That's foregoing due to prescriptions. People are also reporting that they're more likely to go see doctors as a result. Now, I'll get to COVID in a minute. That hasn't been true this year. And people now have greater access to care and improved health outcomes. Remember, we showed up as being 11th of all the industrialized countries in health outcomes, but things like early cancer detection and therefore cancer being curable is now happening at greater rates due to the ACA. Now, another reason we have more coverage is that we have something called marketplaces, which in California are called Covered California. And this allows somebody who wants to buy insurance but doesn't qualify for Medi-Cal, somebody between 138% of the poverty level and 400%, and that's now going to be increased due to the legislation of the bailout, if you will, the recent one that was passed in Washington for COVID. Now more people are going to be allowed access to a marketplace. And what it allows you to do is go on a website and pick insurance that you can afford. Now, unfortunately, a lot of people still can't afford it. But what makes it affordable is that people who go on there get basically a big tax deduction to help them afford that coverage. And that tax deduction is now going to go up. So these tax subsidies are, we hope, are going to see more people insured very soon. And this also gives, because states are going to be offered, the states that haven't expanded more money, it gives them stronger incentives to expand. Medicare for all. Well, as you know, some of the candidates who ran again, who were vying to be the presidential nominee for the Democratic Party, wanted Medicare for all. And that is, we just take Medicare and everybody would get it. The problem is many people like their private health insurance, which is in some ways a lot better because the out-of-pocket costs are less, particularly if the premium you pay is subsidized. The other thing that you will hear about Medicare for all and also single payer is physicians don't want to take a cut in what they're paid. And one of the problems that we know is that doctors are more likely to take private insurance than they are Medicare, and less likely to be agreeable to take reimbursements from Medi-Cal. Medi-Cal reimbursement is 70% of Medicare, and Medicare is about half of what private reimbursement is. That means access to people who are poorer is very, very challenged. So Medicare for all, unless we did something about what the reimbursement was, it might mean that we'd end up with a two-class system. And I can explain if we have time. That's what's happened in several other countries. Now, what might the future hold? Joe Biden wanted a public option to go on those exchanges. And that might be an option to buy into Medicare, which might be less expensive for some people, but we don't have any details about how that's going to be. And we don't have any details about how it's going to be paid for. It might be that wealthier folks help pay for it. What you might not know, for example, is that when we got the Affordable Care Act, people who are wealthier are paying a higher fraction of their taxes that go towards making the ACA, the Affordable Care Act, possible, and that wealthy people are paying a lot more for their Medicare premiums than they were paying before. So whereas some people still only pay maybe $200 a month, if you're wealthy, it's about $750. Another thing we've got to tackle is a provider shortage. We don't have enough primary care physicians or people in behavioral and mental health to take care of our needs. And this is particularly true for people who don't take Medi-Cal. Now, many states, and I think we're going to hear this soon, are talking about moving to a single payer, which is we would get rid of private insurance, Medicare and Medi-Cal, and in the state of California, we'd have just one insurance that we would all get. Now, countries like Canada have this. Most people believe that in Canada, everybody has the same thing. But the reason why, if you want a single payer, it's really encouraging, is that what most people don't know is that the single payer in Canada, which covers everybody, is specific to the province you live in. They're pretty much all the same, but there are subtle differences. And so a single payer, we might be able to do that if states had the option to do it or voted it in, but it would come with some of the problems. So Canada does that. Germany has a system where everyone is covered, but private insurance is the coverage for everybody. And in your own locality, you get to choose. But the reimbursement rates and what it costs are regulated by the area in which you live. And there's some areas, there are other things that are legislated by Germany as a whole. The UK is the only socialized medical system in the wealthy countries in the United States. There, every physician works for the government, all the hospitals are owned by the government, and everybody's covered. And people love it there. And they do much better on costs and outcomes, and they're less costly. They're the least costly of the wealthiest countries that I showed you at the beginning. But what's beginning to happen in places like Germany, not in Germany, but in Canada a little bit, and in the UK a lot, is private insurance has come about that people can buy. And what it allows them to do is go to a doctor and skip a line. So if you're wealthier and you buy private insurance, you can go to the doctor, same doctor, but more quickly because they're paid more. And so the question to think about is, if that ever happens here, do we want anything like another private insurance on top of that? Which means that there are still two strata, people who have private insurance and people who have public coverage. So let me just end. I don't have a slide on the pandemic. The pandemic has exposed all of these inequities, and we call them disparities in care. In case you don't know, people who are African American, who are Latino, people who are Native Americans, Native Hawaiians, their rate of getting COVID is higher and their death rates are much higher. And there are a lot of things we have to do with them. Some of them have to do with insurance, but a lot of them have to do with what we do in our communities to provide them access to care, what we do to help them because they can't eat, and that hurts their outcomes because they live and they share apartments with so many people very often. We're going to have to tackle something that we call the social determinants to get rid of that. Now, these disparities people know about them because if you read the LA Times or you listen to the news, it's on the news. But you know what? I've been in this field for 40 years. They've existed all along, and we haven't done anything about it. And in my view, if ever there was a time, now there was a time. It's not fair to have inequities in who dies. So let me end there and turn it over to our next speaker. And hopefully this will engage us in a very healthy, spirited conversation later. Thanks for listening.
Yes, thank you so much. We've got some questions in the comments. I look forward to getting to those. Some of those might even get answered a bit by or elucidated a little bit more by Jenni Chang. She is going to be sharing a little bit about that legislation that's coming up in California as was previewed. So I'm looking forward to hear more about that. Thank you.
And two people did put questions in the chat, and we can address those later.
Are you waiting for me to speak next? Are we?
Yeah, we're going to go straight to you because I think you're going to tie in some of that based on the legislation that's coming from California, the advocacy related to that. I'm certainly looking forward to how folks like us as individuals or as a club can get involved to support those efforts. And then we'll have some questions to tie in each of your conversations.
Sure. I mean, AB 1400 is out. That's the new single payer bill in California. Principal author being Kalra. This bill has like an insane number of authors, co-authors. So much that even the legislative stuff is like, that's nuts. But it's great because I hope all of them are activated to mobilize on this. It is a stronger bill than 562 from everyone we're speaking to. The economists also say it's stronger. There's some debate if you're really versed in it, about capitation and such. But it covers everybody. So undocumented and incarcerated people. There's so much about this bill that really resonates with everybody in, nobody out. With the organization I come from, just to introduce myself, I'm the communications director with California Alliance for Retired Americans. So I work with many seniors. And the really exciting thing about this bill for them is to see long-term supports and services, which is a really hot issue right now. And of course, with the pandemic, we saw how COVID-19 really struck the nursing homes. It just because our seniors are on Medicare doesn't mean that they're safe. We need our public agencies really empowered. And of course, it has vision care and has podiatry. So for that reason, our legislative staff our legislative committee, which is made up of 40 people, had no problem unanimously endorsing this bill. And we're personally going to be, our organization is going to be lobbying the 120 offices of the legislature to get more sponsors for this bill as much as we can to push this. I mean, we'd love it for it to pass. That's the goal. But we want to take this time to pressure the governor, get him to ask for the federal waivers. And there's some debate about whether we should ask for the federal waivers first or pass legislation first, because I think the ACA has technocratic language that says you need to pass legislation and then ask for the waivers. But there are simultaneous efforts going on right now. So we're of the opinion that we should help both efforts, because imagine if the governor did give the green light, that would empower the legislature. And I think it would, usher the bill to go through. It's kind of like Biden and the PRO Act. To have a pro-labor president really excites labor force. So, of course, there's those two efforts. And then there's also the anti-recall effort. And single payer activists are very much, we're trying to rally more support for that, because we don't have a governor such as Newsom who, campaigned on single payer at the least to sign legislation when it gets to his desk. Hopefully he's not like Brown, who I'm told was secretly like, don't let this get to my desk. We are going to have faith in Newsom and really fight the recall. So that's part of the campaign as well. And I think this fight is going to be a multi-step process. We have a bill now, which I could talk a little bit more about. It addresses, I'll talk about that in a second, but we have what it does in concept, and there in the bill language, in the introduction, it says that this bill and the arbiters would introduce a second bill to address the financing. So that's the part that still needs to be worked out. And I'm saying that now because that still comes up. They're like, why didn't you put the financing in there? That was the biggest argument against 562, SB 562 being the previous single payer bill. But they're going to do a whole new financing scheme with that. And with the new HHS head, Becerra now, lucky for us, being a very pro single payer supporter, likely it would be that agency and the legislature, the governor's office, and the stakeholders coming to the table and figuring out how to finance this. That said, it would provide global budgets for institutional providers. Those are if you're familiar. And it would also reduce healthcare spending, of course, improve care. Right now, the bill, people are like, where is the bill? Right now, the bill is being studied by an agency at Berkeley and UC Berkeley in order to see how much it would cost. The nurses have reported that there's potentially bad players on that board. So we make it an outrageous number like we did with SB 562. But I hope they're prepared to fight back. I think they're trying to get ahead of it. But, I think politically, like this has been proven, like we have the studies to prove that this is going to save money. We have models. We're not creating the model, right?
And Jenni, can you clarify a bit about the waiver and why that's critical to make single payer possible? We likely have some attendees that want a little bit more background information on what's going to be needed to actually make this possible in California.
The waiver is about, so right now, because you always hear, those of you who've been following this, you always hear, 70% of our healthcare system in California is funded by public dollars. That includes money from Medicare, Medicaid, CHIP, and other public programs. But we can't utilize that money as a state, even though we're, my understanding is the 5th largest economy in the world, which is incredible. We should be able to do this, but we can't just use those monies however we want. It's taxpayer federal dollars. So the waivers, and this is written into the ACA, would allow us to use those monies to create our own fund, the single payer trust. So we need permission to do that. And the governor needs to ask for those waivers. He's already asked for those waivers under the Trump administration. So this is not a provocative ask. We're not asking him to do, we're not like, hey, do this wild, crazy thing. Well, what about this? He did that already. So we're like, why don't you do it under the Biden administration? Does that help?
Yeah, that does. And we actually had a previous question that I think fits in right here really well. Did any other states ask for a waiver under the Trump administration? And are there other states looking to do that again?
I don't know if other states asked under the Trump administration,
Okay.
but there are efforts in Washington, New York, several other states, Oregon, Maryland, they're pushing for single payer. Texas has a single payer bill. The momentum is really strong. I think the states pushing this is not that different from the provinces in Canada. Boom, boom, boom. We got some feedback. I think this is the way we're going to get it. Either one of the states will go first, or there'll just be enough states pressuring that maybe Biden will not be so against it. But it's the same as 562, no premiums, co-pays, deductibles, no cost sharing. So I don't know what else I can answer here for you. I can definitely go into the actions that are available. But if we have any other kind of bill questions, I can try to help with that.
Let's definitely go. Oh, we do have a question. Do you want to go ahead and drop it into the chat for me? You're on mute. If you want to unmute and throw it out there, that's good too.
Yeah, probably easiest. My typing isn't the best. With respect to the waivers and the return or I guess the compensation of the state for what would be their expenses associated with Medicare, how much is it anticipated that will underwrite the total cost of the program? And I guess the other piece is that what you made, I don't know if you said it in your piece or whether it was provided before, but that there is likely to be a sliding scale relative to offsetting costs.
That's a good question. I think it would be a progressive tax. Discussion has always been a progressive tax. And the studies have shown, I don't know to what percentage the federal dollars versus our state public dollars make up the 70%, but in total it would be 70%. But the studies were, cost savings the biggest thing, and the governor set up this commission called Healthy California for All, and they did an analysis, and in it they didn't include the cost savings, which was preposterous. So there was so much pushback because it's like you had these great commissioners, you had all these, over a dozen commissioners, and so the progressive, quote unquote progressive, the ones who fully support single payer were outraged. Like, what kind of analysis is this where you don't talk about the savings? But accounting for the savings, and on that commission, there were some rock stars, including Dr. William Xiao, who is the creator of the Taiwanese system. He's a professor, economist. He knows his stuff. So we have faith in the policy. It's really about political will at this point. And the new effort with the nurses, and also Healthy California Now, is to, go through the Democratic Party and really organize the central committees, the neighborhood councils, and the delegates in the ADEM races. All of this has just been building up, and now we're at this meeting now where I'd love to share the details.
Yeah. So we've got a few questions specifically about this single payer concept. And then I'm going to go back into talking about disparities of care and some reimbursement concerns, some of the topics that we previously talked about. But first, in talking about single payer, a couple questions that we've gotten is, are there any other states that already have single payer? I think you said the answer is no. What federal government, why the federal government would be hesitant? Like, what does the federal government have to lose in giving waivers to states that ask for it? And then along with that, is there any congressional action that would be needed? Right? Like, is it literally just the federal government approve the waiver and then we've got the green light? Or is there any other steps that we're going to need to take in order to get this going?
The waivers would be granted by HHS. So we have Javier Becerra there now, and that's what's very promising and why the activists today were so excited. We should send him thank you and congratulations and really butter him up. be close to him. I think a thank you campaign actually would be in order. So my understanding is he would work with the legislature and the stakeholders. Sorry, I need to stop reading the chat. And then, sorry, you asked 3 questions. I think I'm answering your last one. Would they grant the federal waivers? What do they have to lose?
Yeah, like why would they have any hesitation? If a state asks, why not just give it to them?
I think the fear is that, I mean, the lobbyists being in Washington, the 2 most powerful being pharmaceutical industry and insurance industry, are going to make it sound like this is going to rock the boat and public option is the way, and you're going to wipe out jobs and just we're going to reduce quality of care. They have so many just frankly ridiculous arguments because, like, look at our system now, and, you know. And so I think probably the administration is just like Obama. Obama was a single payer supporter and then had to figure out how to work with 2 sides, 2 opinions of the country.
Yeah.
So granting waivers would start that domino effect.
Yeah. And this might be a good point to kind of intersect these 2 conversations, because previously we heard a little bit of how private insurance oftentimes ends up layering on top of this single payer system. And we'd really like to, questions in the chat, we'd really like to kind of elucidate if we have any studies on the impacts of disparity of care, the social determinants of health. If we were to put forth a policy like that, have we seen the effects of that? And if it is so clear, does that undercut the opposition that we see, right? I mean, obviously it then becomes an informational campaign, but you spoke a bit to what the opposition campaigns are. Debbie, can you speak at all to what we see in other countries or what studies and what models have shown to kind of inform that conversation?
And also there's a lot more than Jenny mentioned of organizations against this. Hospitals, the American Hospital Association will come out and say, we can't exist through what we expect to be paid. For example, insurers will say, oh, we're a huge industry, you mentioned. We're going to have to lay off a lot of people. So you're going to see a lot of opposition coming from it. Now, as for other countries that are single payers, those countries that have it love it. And I guess the best proof is almost in that first slide that I showed. Canada has a single payer. Their health outcomes are much better. Great Britain is a single payer, even though it's all government run. It's only one thing in the country. They do a lot better. They don't have a single payer in Germany, but they have universal insurance that is required. So everybody pretty much does better on every aspect. And one of the things that that was there that I'll mention, and this has to do with cost. Private insurers, for every dollar you spend on your premium, okay, 20 cents of that goes for administrative costs. This is what it costs insurers to negotiate with physicians, to pay their claims, to look and decide what medicine is going to be on the formulary, all those kinds of things. Now, to give you an idea, if our single payer was to be something like Medicare, Medicare spends 3% administratively, 3 cents versus 20 cents. And that's pretty much what it is in every other country. And one of the things I want to also say that Jenny mentioned, but I think we need to expand on, because it doesn't have anything to do with single payer, but it's something we've got to do something about. Jenny was absolutely right in mentioning long-term services and supports. These are the kinds of things that people who are getting older, like I am, need when they get really sick. Now, I don't know how many of you knew this, but if you go to a nursing home, Medicare doesn't cover that. Most people don't have coverage for that. It has to come out of your pocket. It could cost you $100,000 a year. There's now a movement called hospital at home to try and reduce the cost to allow you to get care, often virtually, to support you at home, but that this is not reimbursable yet. So if we were to have a single payer system, or we were to have a major revision of the ACA or something like that, long-term services and supports would have to be addressed. Now, if you were all Democrats, the beloved Teddy Kennedy actually, when the ACA was passed, actually had proposed a provision that the ACA add long-term care insurance. But he pulled it knowing that it could doom the ACA because too few people were going to vote for it. So we have a lot of things to tackle, and single payer would help many things, but not all of them.
Mm-hmm.
But it's a place to start if you like that kind of plan. But as I say, a lot of physicians wouldn't like it.
Yeah. And I want to touch on that for sure. I mean, because the concern is always, how is this going to impact people currently in the industry? And I know, like, when we're looking to the green revolution, the argument is oftentimes made, let's figure out a way to incorporate folks that are involved in fossil fuels to, you know, pave the way to this new system. I'm really interested in exploring a little bit about the, I guess, the successful line of argumentation for this information campaign. How do we convince folks that the stats and studies and everything are on our side? Because I don't believe that, you know, just a battle to the wits is normally successful. But before that, I certainly want to recognize and welcome Assemblymember Kalra. Thank you so much for joining us. Yeah. And if you have something to add on that particular question, and you may be a wealth of knowledge of that as well, because I think that if we can win some folks over to our side, it makes it the pathway to that much easier. Thanks so much for joining us.
Thank you so much, Brittany. Thank you all for inviting me. My name is Ash Kalra. I'm an assembly member from District 27 in San Jose. Very proud to be the author of AB 1400. CalCare, which is a single payer program here in California. It is focused on creating the policy that would create a single payer program. There would also have to be other actions taken in terms of the funding. But before you can do anything, you have to agree that you want single payer, and look, this is what it's going to look like. That's what this bill does, and we're having ongoing negotiations and discussions and conversations about how to move the different levers as it applies to funding. Because the reality is, and this is to Brittany's point, that we're going to be hit by the opposition on so many different fronts. They can't change the facts. And the fact, just like you talk about climate change, someone may be able to argue against it, but the facts are clear. And the facts are very clear that our healthcare system is the most expensive in the world. And by far does not create the best outcomes, especially when you consider the many millions without insurance and the many, many millions on top of that that are underinsured or don't have access. The way I put it is that, you can give me a business card of some guy that sells Lamborghinis. Well, I have access to a Lamborghini, but I look at my bank account and you say, you know what? I'm not getting a bit Lamborghini this month. So you can give someone, a card and say, well, you have a $6,000 deductible. For a lot of families, that basically means healthcare is out of reach for them. you're talking about families that can barely survive paying rent and getting by. And so what they do is they just don't access healthcare. Some of the arguments people say is, oh, well, if you get healthcare, you're gonna have to ration. If we have we're already rationing healthcare with our current system by people already not either not having insurance, or people being underinsured and worried about co-pays and premiums, and they don't even access the supposed insurance they have. We currently have a system with rationing. We currently have a system where doctors have to be on the phone for hours to get approval for what they deem to be the best course of action for their patient. And so there is no doubt that right now, so estimates are as high as $450 billion a year for our current system. Estimates for a single payer system are as much as $400 billion a year. Well, it doesn't take a rocket scientist to see that, hey, that's tens of billions of dollars less for single payer, plus everyone's covered, plus you have dental, plus you have vision, plus you have long-term care. I was the chair of the Aging and Long-Term Care Committee in the State Assembly my first 2 years. It's a complete crisis right now in terms of not being able to have long-term care. And keep in mind, long-term care is not just elderly, but those that may get injured or have some kind of illness or disability at a younger age. We all pay for that. Whether it's a family having to find ways to, either one person leaves their job to be a caretaker, or all their savings goes into taking care of a loved one. And so, we know that there is a better way to make sure everyone's cared for. Now, the problem we're going to have is not on the merits. The facts are on our side. We can just look around the world, and it's quite obvious that the way we're doing it is not the way to do it. But the way we are doing it has been cemented because of the profiteering that's coming off, that's being sucked out of us. And so don't for any moment or any stretch of your imagination believe that they're not going to do whatever it takes to hold on to that money. So we will argue and debate passionately about the facts. The facts won't matter so much to those that oppose. They're going to say, oh, you're going to lose your insurance. You're going to lose all your health. And then, when people are afraid of losing their insurance, or they say, I really like my insurance, what they really mean is they like the access to the doctors they have, to the hospitals they have. They like, the fact that they actually have meaningful access to healthcare. That's not going to go away. We're just going to make sure everyone has that. And you don't have to be on the phone with your insurance companies, company for hours on end, or have your doctor begging or you begging to get something treated, or have an insurance company send a customer a letter saying, oh, by the way, we can't cover all this. Why don't you start a GoFundMe account? When insurance companies are literally telling patients to start GoFundMe accounts, the system is broken. So we have to argue the facts. We have to be passionate about it, but let's make no mistake about it. They're going to do whatever it takes. This is politics. This is going to be a throwdown, and we have to lead with love, with compassion, with a clarity of mind and of heart, that the facts are there on our side. The morality is on our side. The people are on our side, but it's going to take a whole lot of work, and it will take a few years of work to get this done in terms of both the policy and the funding, and to make sure that we combat not just the naysayers, but we're talking about professional, political consultants, an army of lawyers. They're going to lobbyists. They're going to fight at every turn. I don't know if you ever see the, and some of you may know Wendell, what's his last, he used to work for the insurance. He used to be a VP for Cigna. And he speaks very well to how they were trained on how to lie about the Canadian healthcare system. Oh, it's horrible. You're gonna be, they ration care. I mean, they were trained on how to lie and undercut every argument that in any way took profit away from the insurance companies. So let's be prepared for that courageous battle ahead. And let's know that, at the end of the day, I'm doing this because, we all have a mortality of us. I have a political mortality. I don't know how long I'm going to be in a position to introduce bills and to fight for what I believe in. And as long as I have the voice and the ability to do it, I'm going to do it. I'm not doing it for myself. If I do it, and because I do it 5 years from now, someone else gets the credit for it, that's fine. As long as we're saving lives and bringing healthcare to every single person that lives in our state, that's the goal. And so be ready, be fierce, be positive, be loving, And that's how we're going to win this battle.
Yes. Thank you. Thank you so much for that. And thank you for your advocacy, for your leadership. I see we do have a couple of hands raised, but we do have some questions in the chat that I want to get to first. But one thing that I want to highlight that I love hearing, this is like music to my ears, hearing a politician talk about leading an argument with empathy, because we are talking about the livelihoods of doctors that are concerned about reimbursements. And one of the questions was about what determines that reimbursement. Is there any way to peg the reimbursement to the actual cost of what's being done? And secondly, the domino effect of how the cost of reimbursement and people accepting that reimbursement impacts access to care. And is that issue completely absolved if this policy goes through? Can any of our speakers kind of speak to those things happening in conjunction with one another?
Yeah, I can, at least, and then we can hear from a congressman who may disagree with some of the things. I just wrote in the chat back to Dr. Lightfoot, who asked, is there any evidence that reimbursement affects access to care? There's thousands and thousands of studies that show that it does, because lots of people won't see certain patients, see them because they're not reimbursed enough. So one of the questions with single payer is, will doctors be paid enough that they're going to agree to see everybody who's covered versus require people to go outside the system and pay them? And that remains to be seen. And I think, that's something to really worry about. Somebody mentioned that there was a study of how much this was going to cost going on at UC Berkeley. And it certainly administratively should cost less. And it does in every country where they regulate what the reimbursement is. One of the things that could happen, which as far as I'm concerned would be a good thing, but this will come up in the cost estimates, is that every time you extend insurance coverage to people who don't have it, the demand for services goes up. That is, people see doctors who didn't before because they couldn't afford it. That's going to push costs up. But in the longer run, that should make people healthier. And so the question is, are we going to be willing to wait for that day? And I think personally, it's worth waiting for. But not everybody is going to say that. So if you see a higher projected cost, part of it will be for that reason. But as I say, other countries have controlled that by having a single payer.
And I would add, but I think that there isn't. I think that honestly, the concern, legitimate concern, is something that can be addressed in terms of compensation for doctors. It's something I'm taking very seriously in the bill. We do have provisions that allow for if someone's serving in a rural community or underserved community to have that taken into account and how much they get paid. Also, I want to look really clearly at how we could do loan forgiveness for doctors and nurses to attract more into the profession. That's a huge burden. But ultimately, look, right now, Medicare, as was mentioned by the professor, has very low administrative costs. We anticipate we're going to save a whole bunch of money by transferring or by the transition to a single payer. With that, we feel, especially if you're not doling out all this money to insurance companies, I want doctors to be paid. I want nurses to be paid. I don't want. The idea is that we're gonna pay those that are actually providing the service, and we can do that. And not only can we do it. Right now, I was talking to someone from CMA, the Medical Association, and they were saying how like a lot of young doctors that want to go to family practice, something, they become specialists because that's the only way they can pay their loans back because they make a bunch of money. We can flip that and actually start compensating those that are doing general practice, family practice, pediatricians, and that will in turn give better quality care in preventative care. And so I believe that we can compensate our doctors just as well. Because it's not going to be right now. Medicare reimbursement sometimes is lower than private or than private reimbursement because of the way the system is set up. And the profiteering that occurs. You reduce that profiteering, and keep in mind that right now Medicare takes care of the costliest patients, the elderly. If you actually include everyone else in there from, from 0 to 65, 20-year-olds, 30-year-olds, 40-year-olds paying in and actually being part of that system, that's going to further drive down the overall cost of the healthcare system.
I really agree. And I'd like to say to our Congressman Kyra, one of the things to think about if this happens is having reimbursement for things that are now not considered medical care, these social determinants of health, which we really need to address. And if the state did that, I think it would be looked at nationally, but it would be could make a huge difference.
Yeah, absolutely.
So, and after this last question in the chat, we're going to get to the hands that are raised. All of you have mentioned the long-term benefits of, closing the gap of healthcare, of lowering the overall cost. How long-term are we looking? Is California looking to be the case study? Or do we have to look internationally to see what this transition is going to look like? And how do we navigate those waters?
We are trying to lead nationally, because I think that it's unlikely that you're going to get to do a national program. If you look at Canada started with one state. Of course, it was a few decades ago as Saskatchewan, but I think it would be similar to that kind of program where every state would have its own program, and the federal government would help to fund it, and some parameters of what you have to cover and what have you. But there's nothing to really compare to. There's definitely single payer programs that we're looking at to compare to in terms of setting up the program, but there's nothing that we can compare to in terms of this massive transition happening now. If we did this 70 years ago, it would have been different. But right now, to have this massive transition is going to be an undertaking unlike anything the state has ever done. And we have to be realistic about it. But at the same time, as Jenni says in the chat, we are the 5th largest economy in the world. We can do it, but it's going to be, it takes political will, it takes policy, it takes academics, folks like the professor that can really help to advise on the best way to go about it. But nothing's been done like this before, even internationally at this moment in time. Most nations that have it did it a long time ago. And, so.
Yeah. Okay. I think we're going to squeeze a few more questions in. Andy, what was it that you had to ask about?
2 minutes.
Okay. A couple of comments. One, this is also an area some of you have heard me lecture on the same subject. Let me make a couple of comments that I want to make. One is, one of the reasons why the compensation to the medical profession in Germany is lower than it is here, and can be lower, is because the education is free. I mean, basically, they're supporting higher education through the federal government. So your doctors, as well as others, are not dealing with massive student debt and student costs and all the rest of it. And so whether it's paying off the debt or basically paying for medical education, we're going to have to focus on that issue. You can't expect a doctor to take hundreds of thousands of dollars of debt and then not be able to earn enough money to pay it off. So this is tied to education. The other thing a couple other things I want to mention is, you walk into any doctor's office now, and there are probably more people working on dealing with billing and billing all the insurance companies and chasing down money and what have you, that you would not need in that office. But that means they don't have a job. You now have literally millions of people employed in the healthcare industry, that not doing anything having to do with healthcare, but playing with the health insurance industry. When Bernie Sanders proposed his bill, he also had a provision for a 5-year transition program where he would help provide job support and financial support to transition the people that you're not going to be hiring. You're going to be firing hundreds and hundreds and thousands of people that are now working for Blue Cross, Blue Shield, all these other agencies. So you're going to have to deal with that. The third thing is that, understand now that our model, for reasons that come out of World War II, and I won't get into, is that most people who have health insurance a major part, as much as 70, 80% of the cost of their health insurance is paid by their employer as a benefit. What you're going to have to deal with now is basically say to the corporate world, hey, look, you're having to negotiate with your unions about and your workers about healthcare. You're having to negotiate with the insurance companies as to which insurance company you're going to hire. You can be relieved of all of that. You won't have to deal with this. This will all be covered through the government things. But we're going to save you millions of dollars that you're now paying for health insurance for your workers. We're going to expect you to keep contributing that. So one source of the money is that you're going to have to, and what Sanders was proposing was that basically whatever the corporations are paying for health insurance for their workers, they're going to have to keep paying about 80% of it.
Yes.
But it'll be paid as a tax to help cover the cost of public health care, the single payer health care, because they'll be out of the business and they will save a lot of money. So there's a lot of wrinkles to this, and a lot of us have done a lot of thinking about what the bits and pieces of this are. It's absolutely doable, but you are going to have to, you
Yes.
now have a large number of corporate executives who are earning $1 million a year and more, working in Blue Cross, Blue Shield, blah, 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 who are not going to earn that money.
Well, I'm not as concerned about the corporate executives or earning.
Well, in terms of political opposition, I am.
Oh, that's why they're going to fight it, because
Yeah.
they're buying mansions with our money and not
Right,
giving,
exactly.
not because we're getting healthcare. I am concerned about the clerks, the administrators, and all that. And if you look in Jenni put some of the provisions that are in the bill, it's similar to the Sanders concept of budgeting some of the money from CalCare to that transition. Keep in mind, CalCare itself is going to need a lot of workers, right, to administer the program, but we do have that incorporated. Secondly, to your point, Andy, is absolutely, this is a boon for employers. I can tell you, and I used to negotiate as when I was in the city council in San Jose, half the time we spent negotiating with unions was on healthcare, co-pays, premiums. Okay, we're going to give a little bit more here. We're going to get a better plan there. And we would end up paying more and they would end up getting less. Private sector employers do this all the time. They have huge sections of the HR department focus on just what can they save a few bucks on healthcare, and they end up giving less than they want to their employees because they can't afford it anymore. And it really is such a confusing way to allocate healthcare through employers. It doesn't make sense. We are stuck with it right now. It is like breaking something out of cement, as I said earlier. So that's not easy to do. But if we were starting a healthcare system on day one, no one would come up with the system that we came up with in 1,000 years, because it clearly was not designed to actually make sure that people are being taken care of, including employers.
Yeah, absolutely. We have one last question to try to get to quickly. Sir? Yeah.
Great. Thank you. Thank you, Ash, for again bringing this very important subject to the attention of your colleagues. I have a comment and then a question. The comment is, it seems to me that given the history of the opposition positions on this subject and their notorious kind of fabrication of facts and overwhelming PR kind of attempts to, again, defeat anything that comes close to what you're proposing or what we hope will be and what we hope will be successful. Does that, again, it just seems to me that your colleagues should take into account the fact that the crying of the industry should perhaps be a little bit less concerning to them. Is this a constitutional amendment, or is it going to be passed by the legislature? And three, if one uses the model of Kaiser, where physicians are paid a salary to serve the members, if one costs that system out and translates it over to the cost of running the state program, the one single payer program, how do they compare?
So those are all good questions. So I'll start with the last one. There are provisions in the single payer bill regarding global budgeting. And that is what, Kaiser does, a form of global budgeting, where you basically, okay, a patient is accounted for, and then they can go to whatever doctor they need. They just anything within the system, and essentially that that global budgeting for that particular patient is considered, rather than every single fee for service is individually accounted for. And so a system like Kaiser actually is probably better suited than almost any other private system for single payer. Again, remember, we're not going, this is not the English system. We're not taking over. This is not government run healthcare. It's the government paying. We still want the Kaisers of the world and others to still provide. Now, they're going to come out and oppose because they're, again, making a whole lot of money off the current system. But the reality is that a system like Kaiser is better suited than most to adapt to a single payer environment, because they already do a global budgeting type system. And what was the second question you had? The second point?
Yeah, the second was, and again, associated with it was, given the fact that, given the fact that the kind of PR jobs that are being done by the industries that will oppose this have been shown to be somewhat exaggerated in the past, are your colleagues at all insulated from those, and can they kind of oppose that and just simply vote their conscience? And the other one, is this a constitutional amendment, or will it be passed by the legislature?
So this bill itself is not a constitutional amendment. We don't need a constitutional amendment necessarily to set up a program like it. Where we would need a constitutional amendment is on some of the funding pieces. So, for example, if we look, this is not as simple as saying, okay, we have $450 billion. We're just going to move it over here and pay for single payer. There are multiple funding streams, and there's in order for us. And as mentioned, right now we already pay $200 billion out of our pockets, federal and state money, public money, and then employers pay at least 100 to 150 billion right now. But we're going to have some kind of taxation system, some kind of taxation. Again, out of pocket will be less. There's something that Bernie Sanders always says, make it very clear. Out of pocket for a family is going to be less without the copays and the premiums, and without the filtering out of profit for the industries. But what that does mean is that there's going to likely be some kind of either taxation, or at the very least, some other mechanism like lifting of the GAN limit, which is right now a limit on how much we can expend every year. That may have to go to the voters. So those are constitutional amendments. They do require a 2/3 vote of the legislature, and will likely be a heavier lift. As heavy as 1400 is going to be, those will likely be even a heavier lift to get through the legislature. And then finally, on my colleagues, look, at the end of the day, I'm going to share what this is about and what we're trying to do. And it's for our community, it's for the people. For as long as, for decades now, and every year it seems more and more, moneyed interests have more and more of an influence on politics, generally speaking. I'm one of two assembly members that does not take corporate PAC money. But there are a lot of my colleagues that do take money, and it doesn't influence them. They still look at the policy, they make the right decisions, and I'm just going to speak to their better angels, and because there's no doubt that they're going to be inundated with lobby. Every lobbyist will be hired up in Sacramento and probably half in the Western states. Who knows? But that's where we need the people. We need the people to be able to speak truth to power, to make it clear where the fact is versus the fiction, and the fear. I like to call it fact versus fear. And we need to do it in a way that the people that are in the legislature know that, look, we have their back. If Ash Kalra is putting this forward, we have his back. If so-and-so is voting for this, we've got your back. You can do this. Let's go. We will support you. Because you better believe that moneyed interest, they definitely can threaten either with, hey, we're going to take our money away from you, or guess what? We're going to give our money to someone else to run against you, right? That's a very common political threat. And so we've got to make people feel comfortable knowing that the people are going to have their back,
Yes, good stuff. Thank you for that. If you have any final words, Jenni and Assemblymember Kalra, please share. I do want to direct everyone's attention to the chat. Jenni dropped a link of helpful resources. And I also think there's just been a couple of comments from both Jenni and Mr. Lightfoot, I think, of just like really great language for us to wrap our minds around on how to have this conversation. It's so much better to make this a conversation about, like Assemblymember said, the facts and the people rather than the politics and the baggage that comes along with that. So if you have any final words, Jenni, please share them, and then we'll let the Assemblymember wrap us up, and then we'll move on to our club business. You're on mute.
Let me see here. If you don't mind me sharing my screen, what's the point of talking about this if we're not going to do anything, right? And I'm sure you all are very active, but AB 1400, the nurses have a whole bunch of ways you can get involved. And then there's also some unaffiliated activism that's going on. I think it's important just because it's better than people not getting involved. And as much as people can plug in and just surround the governor and our legislators to pressure them to support all the work that our assembly member is doing. Assemblymember Kalra, thank you so much. I see you getting out there and just going hard for this, and so smart and fiery. You're the perfect leader for this. Thank you. And this whole political mortality thing, wow, go do it. Thank you. Not everyone thinks like that, you know. Okay, so 14, there's a fact sheet here. That's the first link. That's the nurses link. A lot of these are the nurses link. That, you know, they're the arbiters of the bill, so we want to respect. There's activities, events, and resources on that second link. Where's the bill? I'm telling you there. There's also a multi-strategy letter that's been put out by one of the ADEM delegates. And I think this is important in that the anti-recall effort is a good way to get unions and people who are a little skeptical about single payer to come together as Democrats to go against the recall and stand with single payer activists. And it's sort of a nice way to lightly groom people. I'm sorry to use that kind of language, but, you know, warm the waters a bit. So this letter has 3 asks. If you look at these bullet points right here, we want the chair, the vice chair. I think if the Democratic Club here could sign on, that would be fantastic. We want the chair, vice chair. We want resources dedicated to advocating for AB 1400. We want the governor to apply for the state innovation waiver. That would be such a green light. Like I said, if, you know, Biden can support labor in the PRO Act and it galvanized the labor force, like, what? Let's ask for the waiver. Dedicate party resources to rejecting the recall. And so this is a way to build solidarity within the party, you know, and of course our Democratic clubs, you know, when we coalesce, that's power. So we've been asking the clubs to sign on, and, you know, also labor groups like the Los Angeles Young Workers are signing on to this. I'm going to ask the retiree arms to sign it. I'm going to ask the State Labor Federation to sign it because they support single payer. And there's also another letter right here, AB 1400, this template. The chair, Jim Wood, this is, I feel a little more aggressive towards Jim Wood because I saw how he was with 562, but the nurses are all love. And I respect this approach. So this is their letter campaign to Jim Wood. And I'm just going to click on it real quick if you could see it. The nurses put out this template, and he is the chair of the Health Assembly, the Assembly Health Committee. He has not been a strong supporter. I've seen him, you know, during the healthcare hearings with 562. I would say he's slippery. So we want to, and I don't think his district is going to punish him for it. But we're looking into hopefully mobilizing his constituents. But this is one way we could put some pressure, you know, your name, your title, send it in. It's a template. Excuse me, back to. And CNA has an organizing meeting on March 24th. So many of you all are probably part of either unions or other groups. You can bring your group to this meeting and, you know, get involved as an affiliate, really. And there's a lot of really amazing organizations that are part of that. On April 17th, they have a speak out, you know, another car rally. And then I attached something for the National MFA Act. So, But thank you so much. Appreciate your time. And this is a really great forum.
Well, thank you so much for having me. Thank you, Jenni, Jenni's put more time, energy, and into this than I have by far. And I'm so grateful to her years of advocacy and work. And I want to thank all of you for inviting me and for having this real serious conversation about what I believe is really a generational fight. And I was talking to some high school students the other day. I said, look, I'm doing this for you because so many have suffered through healthcare, and I don't want you to have to suffer, not in our country, not because you don't have access to healthcare or a loved one of yours doesn't, a parent, a grandparent. I don't want them to be where we are now and to have to think about, whether, to pay for their kids' medical care or to pay for their prescription medication or get food. That's not how our country should be. It's not just, it's not moral, it's not fiscally sound or smart either. And I would just say this as well, because, it was 4 years ago was a different scenario. And I've been working really well with the nurses, and we have been working really well in having conversations with Dr. Wood, who's the chair of the health committee, and the speaker. And he's generally, Jim was generally a really good, decent guy. He has done a lot of really good things on healthcare, on transparency, on cost cutting. It was challenging a few years ago on Vice for a lot of things, a lot of reasons, including things that were happening outside the building. And that's why with the nurses, we're just trying to promote a very positive, uplifting campaign focused on the policy and the people that this policy would help and support. But again, there's a lot of different forces at play that make it very challenging for all of us that are involved and want to see this happen for all the right reasons. And so again, thank you all so much. Thank you for your interest. Thank you for your advocacy, for your passion. And look, none of us do any of this alone. I certainly have never done anything in my career alone, and I don't take this on as a lone soldier, quite to the contrary. Many times I feel I'm in the back and so many of you are leading, and I'm just honored to be part of this courageous and righteous movement. So thank you all so much.